Absolutely. Well, I think that we should have a session where we just open it to trainees, like a Q&A session. What do you reckon? I know it's kind of ballsy, but
no, but can we
okay.
have like a call-in system? We're gonna have an Ask Me Anything episode for our next episode. Hi, everybody, and welcome to Anesthesia Coffee Break. I'm Lahiru.
And I'm Stan.
And on this episode, yes, Stan is coming up with a very interesting question from the exam, but we're going to take it apart and make it more general about drug toxicity and how to approach that in general. So we'll get into that. And also a performance tip by me. Yeah, the usual disclaimer, which is all of this is going to be really general medical advice for an exam, but please, if you're treating a patient, don't take this as gold, and definitely ask your treating team about more information for your specific patient. So let's get into it. Hey Stan, so let's get into it. Where are we at? Oh, that's right. First of all, we've got some more Patreons to thank. So
yes,
really
shout
happy. Yeah, shout out.
Exciting.
So, thank you so much, Nikki, for being a Patreon, and Phil, as well as Kate. Really appreciate your generosity. Again, all of our funds. We hope to make enough to make a substantial contribution to this Funder Fellow very soon. And when we do that, we're gonna make a big deal out of it, because we're very excited that we can make this channel about helping people pass the exam, and also, yeah, giving away some valuable, I guess, financial assistance to the places that really need it.
Great. Yes. Now, La, you've got a performance tip that you want to share with everyone. What is this?
I've realized that, especially so in lockdown, I think I pretty much just worked the whole time. So I was, going to work and then coming home and doing education stuff and working on the website and the YouTube channel and all the rest of it. And now that, I definitely lost balance. Now that we've come out of lockdown, I'm trying to regain that balance. And I realized that I want to do everything. I just can't do everything I need because I don't have the time anymore. And so I'm really, first of all, I'm, collaborating a lot with people. So, having Stan do this is just amazing, obviously, but also I'm outsourcing stuff. So my performance tip is outsourcing the things that I can outsource, understanding that there might be a bit of a hit to sometimes the quality and exactly the vision of what I want. But that's okay, because, I always think back to the values I want to have. And, really COVID-19 and lockdown made me think about these things. I want to, make sure I spend time with the people I care about, my family, my friends, and make time for that. And that means that I've got to definitely give up a lot of the control over things like the education stuff. So in my example, literally, I've just found a website editor person. I've found someone on Upwork for doing video editing. And I think that's going to just save me a lot of time so that I can just focus on doing what I can do best, which is, I know anesthetics, I know medicine, I can teach that. So I just want to do more of that and less of the tedious tasks of editing, really. Now,
and that makes sense. Yeah, I mean, I think that in terms of, bang for your buck, or where your value is as a person, and as how you can contribute to making, the world a better place, it's really about delivering ideas, delivering, content, and having that creativity and having that time to, be able to be creative, but also at the same time understand that, you value the importance of relationships and developing and nurturing relationships, which again takes time. And so the other aspects, which I think, knowing you for the last, couple of years, especially our journey together with, this podcast, seeing your skills develop with the video editing and as well as the, the sound editing as well, has been incredible to watch and see you learn and grow with this process. But I think that, you're right. These things take time, and it's very, very labor intensive. And I think that, there's an opportunity for someone else to do those tasks.
Yes.
Whilst you can use that time better utilize that time to delivering other aspects of,
yes.
Of your life. I think that there's so much value in that.
And I thought, how could you relate to this to the first part exam? And I think there's a lot of ways you can do it, whether it's outsourcing your cleaning tasks, because again, if you're not naturally a person that loves cleaning, you can get someone else to do that for the time of this exam. If you don't love cooking and making healthy meals, you can get someone to make healthy meals for you. So this isn't getting, a bucket of chicken for the next week from KFC necessarily. It's, making sure you've got healthy food that's regularly available to you. I remember one of my mates, one of his aunties, his family used to pay like an auntie of theirs to make amazing curries for them. And he'd have a whole frozen collection in the freezer and take up most of our freezer space. But it was amazing that he could just have a healthy meal whenever he wanted. And you can think of a lot of tasks that you could outsource when you're time poor in this exam. And I want you to think about that to, just do the best that you can.
Yeah. Well, speaking about outsourcing, I mean, with my Patreon page, I'm outsourcing my weekly session to you tomorrow.
Thanks for that. Yeah.
I mean, and that's such a. I'll tell you what, I've actually been burnt out the last fortnight, I think.
You're doing a lot.
Probably more the last sort of week. And when I say burnt out, more so that, I think that I just sort of need that time just to have that time to do not so much primary stuff, if that makes sense.
Yeah.
And I think it's been really, really nice to have you come aboard and to collaborate with you and, to know that you are going to do an amazing job tomorrow with talking about the mind coaching. So I'm really excited about that as well.
And again, I'm going to talk about this tomorrow in our session, but the fact that, I'm just not a performance coach. I'm not an expert at this, but you just don't have to be an expert to share good ideas. And something I've just learned recently, there's no new ideas. There's just there's just different messengers. And there's a real advantage to sharing a message in the way you think about it, because someone might find it useful. And that's all you're doing. But also the fact that you try to teach something, you try to process something and maybe put something together. It's just the last few days of me typing up this presentation and getting my ideas around a lot of the stuff I've learned in the last couple of years has been incredibly useful. So so everyone tune into Stan's Patreon. Definitely sign up to that. We'll put the link down, obviously, but Stan's doing some amazing stuff with Part 1 teaching on a regular basis. Was it weekly sessions where he's running through his way of doing short answer questions, which I wish I had that resource when I was doing this. And then tomorrow we're gonna do some performance and mindfulness stuff and trying to package what all of the the self-improvement and performance and productivity tips and welfare stuff into one roughly hour session to help first part candidates. Okay, beautiful. So let's get on to this question. Discuss the factors that influence the toxicity of local anesthetics when used for topical anesthesia of skin and mucosa. And this is from 2020 second sitting short answer question paper, question 9. So if you wanted to follow along, that would be the question to go with. But Stan, how did you approach this question? And I think you're going to go a bit more broad with this general techniques.
So I've got a template which I use to think about toxicity of drugs, and I'm going to share this with you, and you can apply it, and you can even adapt it and change it however the way you want. And the way that it works is the idea that the end result is toxicity. Okay, and we're going to think about how or what we do or what happens leads up to that event. And so the first step that I think about is the drug choice.
Actually, and toxicity is so broad, right? So it can be anything that causes an adverse event based on a drug. Is that right?
So a very nice, easy definition of toxicity is, as you said, are the adverse effects of drugs. And certainly you can expand on that. You can say where the adverse effects can be deleterious and also can be fatal or non-fatal. And the other things that you can also add can be reversible or non-reversible as well. But I think for simplicity's sake, you can just say toxicities are the adverse effects of a drug. Okay. And then after that, you can certainly think about the types of toxicities they are, because you can have local toxicity as well as systemic toxicity that can occur. So there is a very wide range of applications to the idea of toxicity. Absolutely.
Go for it. So your framework for toxicity and approaching any drug.
So the framework is, number one, it's about drug choice, because specific drugs will have specific types of toxicities associated with them.
Actually, Stan, what's your full framework just to get started with?
Yeah. So number one is drug choice. And after that, number two is what I call drug exposure across time. And then number three are patient variables affecting that. And ultimately that leads to the idea of toxicity.
Yeah. Okay.
So you think about it, all that, it's that interplay with, giving the drug to the patient, and then what happens in terms of the drug to the body. And then after that, how the, any patient variables affects that in terms of that concentration, which can ultimately lead that to toxicity.
And it's interesting. I'm glad you brought this question up, because I think we all think about drug toxicity all the time. And when you proposed this question, I thought, oh, how do I even think about this? And I just thought, okay, I'll go back to my original frameworks, which have stood well in the test of time, which is pharmaceutics, pharmacokinetics, pharmacodynamics.
Absolutely.
And I've always got the whole patient factors and potentially other drugs and what they do. So maybe as you're going through this, I'll try to link it into my framework to help me understand as well.
Correct. And, for all the keen listeners out there and those with sharp ears, that's exactly what it is. Drug choice is your pharmaceutics. Your drug exposure across time is your pharmacokinetics. Patient variables are your pharmacodynamics. And the reason why I've structured it as such is that it just allows you to have a flow of concepts. In other words, you're able to do concepts with one another. Whereas I think that, whilst pharmaceutics, pharmacokinetics, pharmacodynamics is a really good framework, it tends to just box in those concepts there. And it doesn't allow you to have that continuation where you're able to build on those ideas.
My counter view to that, I guess, is if I say those terms of pharmaceutics, kinetics, dynamics, drug factors, patient factors, other, then the examiner sees that and goes, oh, good, this is something the examiner is familiar with. Like it's kind of a tested modality or framework. Whereas if I give them something different, I'm potentially worried that they won't realize that I know what I'm talking about, maybe. But then I guess it comes down to the detail. Once you put the detail in, everyone knows you know what you're talking about, I suspect.
That's right. Yeah, correct. And I think it should be fairly sort of obvious that, when you're talking about drug choice, when you're talking about drug exposure across time, and you're talking about patient variables, I mean, you spotted it straight away that was pharmaceutics, pharmacokinetics, pharmacodynamics. And I guess, look, if you want to play it safe in a short answer question, what I would have down is I would have those three things down, and you can put those in brackets that those represent those key ideas of pharmaceutics, pharmacokinetics, pharmacodynamics. Because the reason why I'm trying to move away from that is that I think that a lot of times when people use that framework, especially with pharmacokinetics, they start going, all right, so pharmacokinetics, absorption, distribution, metabolism, elimination. Whereas, when I think about the drug exposure across time, what I want to do is I want to tie it in to a formula. And, it's that idea about, when we think about drug exposure across time, it's that idea about clearance, clear about drug. So we know that clearance equals drug, your drug dose divided by your drug exposure across time, which is the area under the curve. And this is where that idea sort of comes from. And it just builds on from those concepts there. And it's about thinking about ideas that affects your clearance, and then ideas that affect your, the drug, or in other words, how much drug you're going to use as well.
Okay.
And also with pharmacodynamics, I think it just helps build up that, that idea that it goes beyond sort of, cardiovascular, respiratory, neuro, which is what a lot of trainees are trained to do. They're taught to think about it systematically, which I think has its place when perhaps, you're hearing a question for the first time. But I think that if you've had time to sort of think about this, you could probably better eloquently explain it in terms of the actual patient variables which are related to that drug. So for example, with local anesthetics, the things that will affect it are going to be things like, we know that acidosis, hypercarbia, hypoxia really worsens local anesthetic toxicity, especially those affecting the heart. And we can go, and that way you can sort of tailor that really specifically to the drug using this framework here.
Right. So let's talk about drug factors then. What do you have in that? Like, what are the specific things and relating to, I guess, local anesthetics even?
Yeah. So first of all, specific to this question, so let's go through this framework and look, you know what we can do is we can sort of do it together.
Yep.
All right. So let's say this question is specifically talking about toxicity of drugs for topical local anesthetics that we use in the skin and mucosa. And then I'm going to ask you, all right, so which local anesthetic drugs do we use for the skin and mucosa? What are the common local anesthetic drugs that you use?
Yeah, common ones, I guess, for skin topical would be, angel cream and EMLA or eutectic mixture of local anesthetics. And then commonly for eyes, you use drops. So that's oxybuprocaine or amethocane. So that's used. And then just off the cuff, then and this is pretty common to all of them, but really, if you've got preservatives that people react to, that is pharmaceutics or your drug choice. Or if they've got an allergy to a specific preservative or the drug itself, that's a major problem. And potentially other additives. So if you've got
and how about for topicalization of mucosa? Do you know, for your fiber optics, what do you use then?
Yeah, so let's say high dose or higher dose lignocaine atomized for mucosa for airway fiber optics. Yeah.
And then how about like anything specific for ENT? Well, we don't really use it, but ENT.
Cocaine, I guess, for nasal propioncaine. So that's really good to think really broadly, because I think when you first look at that question, you might just go into, EMLA cream, but really, wow, there's so many things we use topically and other specialists use topically as well.
Right. And that already provides you the framework already. And I'm glad you said EMLA cream. So EMLA cream has prolocaine in it. And you mentioned some really other good local anesthetic drugs. So amethocane, oxybuprocaine. And you can add that into your framework in terms of that these are the drugs that you can now talk about with regards to toxicity. So then we can divide it further into that. So lignocaine and prolocaine are amides, and cocaine, amethocane, and the one you said, oxybuprocaine, are esters. And so that those would be the types of those would be the choices of the local anesthetic drugs that we use. And then we can talk about the specific toxicities that may be related to them. So I think it's safe to say that, with all those, that with both the amides and esters that we have described, that they all can cause what we call sort of local anesthetic systemic toxicity. And that includes, your CNS toxicity, as well as your cardiovascular toxicity as well. I don't think we don't need to go too much into detail about the mechanisms involved, other than to say that if you give enough lignocaine, you're gonna get seizures. I think that's and if you give enough, it's gonna end up patients gonna have CNS depression. Have you ever been involved with someone with local anesthetic toxicity before, La?
No, not directly, fortunately. But I mean, over time, I think probably every few years there's an incident where there's some severe local anesthetic toxicity reaction, and
you hear about this, don't we? Especially with the amount amount of lignocaine that I think a lot of people are using nowadays, not just for, I guess, for topicalization of airways, but also they use it for tumescent anesthesia as well. I think that's what we've heard multiple times in the news.
Forgive the pun, but it's very, very topical. Yeah.
we won't go too much into detail. Now, what's quite interesting is that lignocaine does have a metabolite, MEGX. It's called monoethyl glycine xylidide, but I just know it as xylidide. Okay, and that has been implicated in seizures. So that's considered to be neurotoxic, and cocaine. I think cocaine does reduce your seizure threshold as well, and that's quite interesting because that's going to be one of the groups that of local anesthetic drugs that we can also discuss about.
So that if I was to get this around my head, that's actually going to say the pharmacodynamics, the actual action of these drugs can cause toxicity in itself. So local anesthetics, they block sodium channels and as well as a few other channels. And this can then the side effects of this is central nervous system inhibitory and excitatory responses. So, starting from ringing in ears, tinnitus, perioral numbness, then going into seizure and coma, and then cardiac toxicity, which generally manifests as, conduction problems, arrhythmias, all the way down to cardiac arrest, and potentially asystole later.
So that's the traditional way of thinking about this. So I'm proposing a different way, and because this will allow you to actually talk about each group and in equal amounts of time. And what I mean by that is that I totally understand that when you talk about cocaine and its CNS and cardiovascular toxicity, that's a pharmacodynamic effect. But what I'm proposing is that is actually very specific to cocaine, and it's something that you are gonna have if you decide to use cocaine. And what I'll do is, with the patient variables in terms of the pharmacodynamic effects, what I will say is that patients who may have cardiac disease are probably more susceptible to the effects of cocaine toxicity, if that makes sense. Yeah. So it actually allows you to bring in another factor in, which says that there are patient factors involved, which can increase the toxicity of drugs. In other words, that you would probably try to minimize or avoid cocaine in someone with known cardiovascular disease. And I think that using this framework allows you to actually describe that quite eloquently, because otherwise, I think like what a lot of candidates would do is they would put that cocaine and the CNS cardiovascular effects into the pharmacodynamics column, and then after that, the pharmacodynamics the section just becomes too large to actually it just becomes a bit messy, if that makes sense. Whereas I think there's a bit of clarity now to sort of say, with the drug choice, if you decide to use cocaine, these are the specific toxicities involved. If you decide to use lignocaine, it's got a metabolite which is implicated in seizures. If you decide to use prilocaine in emlacrine, it's gonna increase your risk of methemoglobin. And if you decide to use esters, and I think esters are implicated in more allergic reactions than amines because of their metabolite PABA, which is the para-aminobenzoic acid, which I think it's also a preservative as well, I believe.
Yeah, in sunscreens actually, isn't it?
Yeah.
So I think I've realized that you're going down the drug first. So you're going at drug-centric toxicity method, and the way I was approaching it was a categorized.
That's right.
Celiac dynamics,
which I think is what we're traditionally taught. Exactly.
Okay. Does that mean that you then within each drug you go through each?
No. Okay. So unless there is a specific a specific sort of toxicity associated with them. So so let's say with muscle relaxants. Okay. Let's say you apply the rule with muscle relaxants. Then with muscle relaxants, that succinylcholine can have specific toxicities such as sex apnea, malignant hypothermia, which is not associated with non-depolarizing muscle relaxants. And then in the third section, where we talk about patient variables, you can talk about variables which can increase your risk of sex apnea. So, or those with pseudocholinesterase deficiencies, or those with genetic disorders.
That makes a lot of sense. Because right now, your method is getting to the point of difference of each agent. So you're getting to the marks very quickly, whereas a general method may get you a broad range of generic answers, may not get you critical marks. And there's a very common practice in the second part exam where you want to get to the point very quickly without too much reliance on frameworks. And I guess my counter to that is, if this was a foreign question, I hadn't really thought about it. I like the fact that you're saying, these are my drugs, my drug choices are these. I will then, and maybe making a statement, I will then talk about toxicities in each of these categories, celiacs, kinetics, dynamics, and just say that as a statement. But then I'm going to talk specifically about cocaine doing this, not forgetting that it is hepatically metabolized and liver failure will cause problems. And maybe that, lignocaine or ropivacaine at a certain dose will cause, it's more cardiac toxic, less smaller CC to CNS ratio. Therefore, cardiac collapse is more likely with bupivacaine and ropivacaine, or and get really specific about each agent.
Yeah. And I think but this is where you can compare and contrast like the different drugs. So, for this, if you were talking about local anesthetics used for regional anesthesia, in your drug choice, you can actually talk about the different CNS ratios of the different local anesthetics. And I think that's where you fit that in. Yes. That's where you fit that in terms of that bupivacaine has a lower CNS ratio than ropivacaine. Mm-hmm. And then in the patient variable section, you can talk about certain pathologies that can increase the risk of toxicity. Yeah. So hypercarbia, acidosis, and also there's also age factors as well. So in the very young or the very old, you might have issues related with your hepatic metabolism, which can increase the drug concentration actually in the system. Mm. Yeah,
that's good. And so, if you were now to talk about each of them, I think we've already mentioned a few things. Would you talk much more about each? So, should we go through?
That's it. That's all I'll mention. So, what I would mention is that all local anesthetics cause local anesthetic systemic toxicity, which is last, which is your CNS and cardiovascular toxicity. And then within the CNS toxicity, I'd add that lignocaine does have a metabolite called MEGX or xylodide, which is neurotoxic, and that cocaine can also lower the seizure threshold. Mm. And then under cardiovascular, I would have that cocaine does cause coronary vasospasms, and can also increase your sympathetic stimulation, which can lead to dysrhythmias. And then after that, I would have that prilocaine is implicated with methemoglobin because of its metabolite orthotoluidine. And then finally, anaphylaxis and allergic and sort of local allergic reactions are more commonly with ester anesthetics than with amide anesthetics.
And then you did mention the things that are common to all of them, and these aren't solely points of difference, but worth mentioning at the end, which is the age changes and disease states. I think
so. I would leave that for my third section. For the patient variables. Yeah. Yes. So for my patient variables, I'd have all those things that very good. I think can affect it. And look, the way that I think about this is that it's like a step. It's like the choice of drug you use will then limit or define what toxicities are possible. So in other words, that's what I'm describing first. I'm going, all right, you've taken drug X. With drug X, these are all the different types of toxicities that are going to be possible when you give drug X. Mm-hmm. When you give it to the patient, a lot of the toxicities are going to be dose dependent. Mm-hmm. And so then this is about that idea in terms of what is going to affect that dose dependency or the drug exposure across time. Okay. Yes. And then the last bit is, with regards, because the thing is, not everyone who has a high concentration of that drug is going to have toxicities. And, we know that some patients are more vulnerable to toxicities than others. And what is it that causes that vulnerability? And that's where you can discuss things like, for local anesthetics, things like age, things which can be related to, hepatic failure, renal failure, as well as, any pathologies. And that's when you can sort of build up that story.
That sounds really good.
Yeah.
Okay, I think that's covered that pretty well then. So we pretty much talked through discussing factors that influence the toxicity of local anesthetics when used for topical anesthesia of skin and mucosa. I like that we went really broad with that. So we're not just talking about just the skin stuff. We're talking about all the different aspects of wave fiber optics and ENT surgery and all the drugs you could use. We're doing a drug-centered approach, specific toxicities, then patient variables and other diseases that might change things. And that way you can probably apply that to any other circumstance, notwithstanding that you could also interact. If you've forgotten stuff, you could use up your other methods of pseudix, kinetics, and dynamics to if you think you've forgotten something, just to re-jog your memory without necessarily mentioning it.
Well, we've already done step one, and we need to go to step two.
Oh, go for it, yeah.
Yeah. So step two is your drug exposure across time.
Yes.
And I think that then we're thinking now about factors that will increase your drug exposure. So number one is going to be the dose that you use. If you use a higher dose, you're going to have more drug exposure. And I think this is where you can also add that, concurrent use of any other local anesthetics. So if you have any other systemic local anesthetic on board, that can also increase your toxicity as well. And I think at this point here, you can talk about how the absorption of drug occurs systematically, okay? And it should be quite evident that mucosa, because it's got less of a skin barrier and more blood flow, it will absorb more local anesthetics than through the skin. And, and this is where you could probably just quickly add in fixed law of diffusion into that.
Yeah, nice.
All right. And I think that one of the things is that a lot of candidates would probably spend time talking about fixed law of diffusion, but I think for this question here, I think it only includes a small proportion of what this answer actually tries to get you to discuss.
It's not talking about the rapidity and comprehensiveness of transfer of a drug. It's talking about toxicity, and it's one statement to talk about fixed law, really.
That's right.
Yep.
Correct. That's right. And then the other thing, in terms of topical local anesthetics is that, you don't want to, like when you put amla cream, you should limit how much you leave it on to the patient. And certainly in the product information, it does talk about that, especially in neonates where they have a very immature hepatic system. You don't want to be leaving on amla cream for longer than an hour. Okay?
Yes.
Yeah. And certainly I think also as well what we sort of think about in terms of frequency of exposure. In other words, that in any 24-hour period, you don't want to be applying multiple amla creams over and over again, because that's going to be increasing your drug exposure across time.
Yeah, good. So you mentioned dose, the amount of time, as well as the tissue and how much would transfer. And then that allows you to give a comprehensive answer about how that drug will affect that particular patient. Okay.
Yeah, correct. And then, specifically with local anesthetics, we think about clearance, and, most for amides, they're hepatically metabolized, and for esters, they are metabolized with plasma esterases. And so the amides are going to be affected with your what we call your clearance from the hepatic system, which is a function of both hepatic blood flow, the degree of protein binding, and as well as the enzyme activity of the hepatic enzyme. So again, knowing those three things, hepatic blood flow, protein binding, and enzyme activity, that will allow you to think about certain pathologies in the patient variables, which are going to be increasing your risk of toxicity. Okay. And I'm jumping ahead here, but just to show how it's sort of linked in, is that, for the patient variables, anything that decreases hepatic blood flow. So for example, in the elderly who've got decreased cardiac output, you've got decreased hepatic blood flow, decreased clearance of, your amide local anesthetics, which can potentially increase the risk of local anesthetic toxicity. And also, in neonates who have a very immature hepatic system, they probably have immature hepatic enzymes, which again decreases the clearance of amide local anesthetics, increasing your drug exposure, increasing your risk of local anesthetic toxicity.
Yeah, nice.
And look for the kidneys. What would I say for the kidneys? For the kidneys, for the local anesthetics, look, probably only relevant, I would think, for lignocain's metabolite, xylidine, which is renally excreted. Otherwise, most local anesthetics are they're hepatically metabolized. Okay. And so I would say that patients with renal dysfunction, the risk is that if you use large doses of lignocaine, the metabolite xylidine, which is neurotoxic, can potentially accumulate. Yeah,
brilliant.
And then after that, you move on to patient variables, and we've sort of discussed some of the aspects of patient variables related to the elderly and their cardiac output and hepatic blood flow, in neonates with immature hepatic enzymes, and also with local anesthetics, you've got to be careful with acidosis and hypercarbia. So the thought is that with CNS toxicity, acidosis and hypercarbia will increase your cerebral blood flow, And when you increase your cerebral blood flow, you're actually increasing the amount of local anesthetics being delivered to the brain. Okay. And also, the idea of acidosis promotes ion trapping. We think about ion trapping when we think about the fetus. And so that can actually increase your risk of toxicity. And with the cardiovascular system, acidosis, hypercarbia, and hypoxia are all cardiovascular depressants. And that's going to promote the cardiovascular collapse that can occur.
Yeah, that's interesting, and maybe worthwhile going into that. So if you have higher CO2, you get more blood flow cerebrally, therefore more delivery to sites that you don't want local anesthetic to go. But also it means that you have the ionized fraction now inside the cell trapped there. That's right. Exerting its bad effects. So that means, I think one of those suggested things that you definitely don't want the CO2 to climb too high in local anesthetic toxicity. You may want to hyperventilate. You want to
keep it normal. Yeah.
Keep it normal.
That's right.
Yeah, good. Excellent.
Absolutely. And I think that's one of the key things. In fact, I think that's one of the key things in any arrest, but more so with local anesthetic toxicities, that you want to avoid the patient being hypercarbic. You want to make sure they're well oxygenated, and you also want to make sure that they're not acidotic. Right. Yeah. And then finally, with related to local anesthetics, you could probably add that there are certain patients who would be at risk of methemoglobin. So there are certain metabolic disorders which are associated with methemoglobin, and also the use of other drugs. So like sodium nitroprusside can actually promote methemoglobin, and you probably want to avoid using prilocaine in those patients there. That's my framework, and you can apply that to any drug. You can do that exercise to muscle relaxants, to induction agents.
So it's probably a good thing, if you want to have a bit of homework, I like the idea of drilling things. So imagine drilling this toxicity type question for all your major classes, your volatiles, toxicity of IV induction agents, muscle relaxants, opioids, local anesthetics, like we just covered, and, anything else. Instead of just learning a drug by itself, learn it in a context, and it just rewires your brain to allow you to memorize a bit better.
Correct. And I quite like this method because it allows you to sort of compare and contrast. So in other words, let's say you do what are the toxicities of inhalational agents? And then you go, all right, drug choice. We know that, most classes of inhalational agents will have dose-dependent effects, both on cardiovascular and, your respiratory system. But are there any specific toxicities associated with specific classes of inhalational agents? Halothane with halothane hepatitis, sevoflurane, potential renal toxicities, potential. So it just allows you just to think about the compare and contrasting idea, and then after that, have a think about in terms of, with regards to the clearance of the volatile agent, whether that's going to be a factor. And then after that, whether any sort of patient variables will increase the risk of toxicity for that agent there.
Oh, thanks, Sam. That is a fantastic summary. And I love the fact it's a different way of approaching to what I normally would have thought, but I feel like it really does get you to the point of difference and the essence of each drug and its problems far sooner than a general method. So I really like that. Yeah.
So feel free to adapt it, change it. You can make it better, which I think that is that whole process about learning and evolving. And, if anyone can think of, a different way of thinking about toxicity, let us know.
Sounds good. I think that's pretty good. That's a good session. Discussing the factors that influence local anesthetic toxicity, and a very good general framework for any drug. Probably leave it there and close now. Thanks, everyone. Thanks so much for watching and listening to Anesthesia Coffee Break. This podcast is out on YouTube as well as on our podcast on any of your normal players, on iTunes, Spotify. If you enjoyed this, please share with anyone who might be interested, and we'll see you next time for the next episode. Thanks a lot. Bye.